I'm here today to talk about the hidden epidemic of smokeless tobacco use. It's an epidemic that's facing children not only in India, but in the United States, Africa, and in places like Sweden. My name is Gregory Connolly. I'm a professor at the Harvard School of Public Health. And I'm sorry I can't be with you here today. I did have trouble in transit, but I'm very happy to congratulate India on winning the Cricket World Cup. We're concerned that the transnational tobacco industry is acquiring the smokeless tobacco industry. That is, the cigarette companies are taking over in the United States, internationally, the manufacture and sale of smokeless tobacco. They're promoting it as a gateway product for youth and as a way to keep adults cigarette smoking. That is, promoting both smokeless tobacco use and cigarette use. We're also concerned about dual use and increasing addiction. If someone is dependent upon smokeless tobacco, it may be a different addiction from cigarette smoking, so it makes treatment harder. Also, harming people who wish to quit, turning to smokeless tobacco thinking it's safer and not stopping nicotine addiction. Finally, undermining public health measures such as clean indoor air, where the manufacturers promote smokeless tobacco as a temporary alternative until they can smoke again. Here, as even in Taiwan, there's a new product called Camel Orbs, a Gutka-like pellet that someone will place in their mouth and it dissolves. It's not only being promoted in the United States, but in Taiwan. Our Food and Drug Administration will now be looking at banning these products under a recently enacted law passed in the United States, whether or not we're going to be allowing manufacturers to come out with new products like these camel-like pellets. Again, there's special risk, early initiation, high risk of dual use. Also, smokeless tobacco has very intensive chemosensory properties, which interact with neurons in the head and neck region, with betel nut, wintergreen, all sorts of additives that may make quitting actually harder than cigarette smoking. We have to be very concerned with that. There is no safe health standard. Despite what Swedish tobacco companies would tell us, the levels we're looking at in the Swedish tobacco smokeless products are 2,000 times greater than what would be allowed in any other consumer product, including nicotine gum to help you quit, or in bacon or beer or other products. We have to remember, though, that where do people use smokeless tobacco? In all of Sweden, it's only 800,000 people. Yet in South Asia, there's 250 million. There's probably more people in the streets of Delhi using smokeless tobacco today than all of Sweden. Yet many international agencies are touting how wonderful the effect of Sweden is, when in fact the real problem, the hidden problem, is with use of smokeless tobacco in South Asia, where we're seeing up to 25% of cancers. We looked at a cancer-causing agent, TSNA, tobacco-specific nitrosamines, and we saw high levels in U.S. snuff, in gall, and somewhat lower levels in Gutka in Swedish snus. But when we compare those levels in Swedish snus and in Gutka or Marchand, they're over 1,200 times greater, the toxicity levels, than what would be deemed to be safe in smoking cessation products like nicotine replacement or by the United States EPA. These are relative risks of 1, these are 1,200. We're also concerned with women. If we just take 6 countries, women's oral cancer rates in India are twice that of the United States, almost 3 times that in Pakistan. Even though we have high smoking rates or lung cancer rates, we're still seeing very large rates. It's somewhat lower for men, but still higher than one would consider to be acceptable. So we must address this problem of smokeless tobacco, particularly among females. These are Swedish studies saying that the Swedish product is safe. Well, if you look at the 2 Swedish studies they've referenced, I can just look at the bottom here on the Schulte study, 57% of of the study respondents were proxies. That is, 57% had been deceased. And what they found, which was intriguing, was in the Schulte study, cigarette smoking didn't cause a risk of mouth cancer. We know that's simply not true. So the studies that are being looked at in Sweden have serious methodological flaws. And when you look at the actual evidence, you do get mouth cancer in the United States and Sweden. And IARC and the European Commission, both looking at this data, have concluded, regardless of whether it be Swedish snus, Indian tobacco, smokeless tobacco, or American snus, they cause oral cancer among humans. Whether it be in Sudan, where we see enormous rates of oral cancer, rapidly spreading to young people throughout Africa, or in the United States. This is nicotine level, looking at different products. This is the American smokeless tobacco, having about 15% of free nicotine. We're looking at Naswar in this slide here, Gull, Connie. All of these levels are sufficient to cause addiction and to maintain dependence among users. Some have argued smokeless tobacco can help people quit. Both IARC and the European Commission that looked at this evidence found there was insufficient evidence of smokeless tobacco being a cessation aid. In anything, it's being designed in the United States to entice people to continue to smoke by giving them low levels of smokeless tobacco. Everyone talks about Sweden having men switch from cigarette smoking to smokeless tobacco. In reality, about 20% of men reported that when they quit smoking, smokeless tobacco played a role. But the vast majority quit because of the effective public health measures in Sweden: higher prices, package warnings, availability of nicotine gum. The most disturbing factor was that among adolescents in Sweden who currently use smokeless tobacco, 71% also smoke, enormously high levels of dual dependence. And we can just go across the border from Sweden to Norway, where we've seen an equally big jump in smokeless tobacco over the past 25 years, from 9 to 33%. But when we look at daily smoking, there is no change in Norway. Men are still smoking at the same rate, so we can't transfer that Swedish data to other countries easily. In the United States, we have seen a 25% increase in smokeless tobacco over the past 6 years. The biggest increase that was significant occurred among our adolescents, going from about 8% almost now to 12% among adolescent males. The most disturbing thing is among adolescent males who are current users of smokeless tobacco, 67% also smoke. So the tobacco industry doesn't want the children to quit smoking, and as they quit smoking, they're promoting smokeless tobacco and creating dual addictions among those groups. Dual use, again, among current boys in the United States that use smokeless tobacco, 66% also use. Among ninth grade boys in Sweden, 71%. In the United States, they keep changing the size of the product and making it more addictive. Here is a snus product that was brought in 4 years ago, 5 years ago, in a small pouch, in a small weight, with small nicotine. They reintroduced it in 2010, tripled the weight, and increased the concentration per gram. So the industry is actively experimenting on how they can come up with a more effective nicotine delivery device. That shouldn't be allowed. We shouldn't allow manufacturers of an unmanufactured product just to go off and conduct drug experiments in our communities, whether it be Delhi, Boston, or in Stockholm. Here again, I can show over the past 3 years, we've seen Marlboro snus. This is a new smokeless tobacco product brought in the United States, where they've increased the levels from 98 to to 9,000 in 3 different brands. Again, they're manipulating and controlling nicotine to cause addiction. We shouldn't let that happen. Here is Facebook or YouTube, and we see youngsters in the United States using social networking to advertise smokeless tobacco. We shouldn't allow that. The Food and Drug Administration in the United States has been given authority to end advertising on internet. We should explore that with the World Trade Organization, with the Framework Convention of Tobacco Control, so it doesn't occur elsewhere. This is, again, the orb I talked about. This is what it looks like. It came out in 2009. Now they put it in a child-proof container. Now in 2011, they've reintroduced it, making it much easier for a child to ingest these. We did research where if a child, an infant, picked up 10 of these tablets from their parent, age 1 to age 2, that child is likely to be poisoned and brought to a hospital for poisoning, and hopefully the child will survive. Nicotine is a dangerous drug. It should not be treated like candy, whether it be through Gutka in India or whether it be through Camel orbs in the United States. Historically, tobacco transitions from an unmanufactured product like pan into a manufactured one, like we see with Gutka today. Innovation generally increases initiation among young people, it enhances dependence, it increases the number of users, and it increases health risks. We should not allow a manufacturer ability to make money take precedence over a nation's right to protect health. This was the decision by the GATT in 1990, where I testified on behalf of WHO. Regretfully, the FCTC was written for cigarettes, not smokeless tobacco. It also avoids trade issues and meaningful regulation. This conference must provide direction to the World Health Organization, to the COP, the Committee of Parties, and to trade bodies like WTO, saying an international company's ability to make a profit, whether it be India or the United States, shouldn't take precedent over a country's ability to end profitability. I'm going to end my slides here with a very simple model. If we want a tobacco-free society, we must affect price, promotions, but more importantly, regulate the product. And in the case of India, there should be no reason why manufacturers can take an unmanufactured product and now put it in tinfoil with a lot of additives and make it very attractive to children. It will only lead, in our experience, to more smokeless tobacco and potentially more cigarette smoking, and the nation will suffer. So regulation of the product, and it may mean slowly eliminating from the market, is a wise public health measure. Just lowering the toxins in the product is not going to work. Trying to affect the nicotine level is not going to work. We must actually regulate the product. I want to thank everyone today for being so attentive. I deeply apologize for not being with you. I hope to return to India very shortly and share my understanding and my knowledge with the brilliant minds within the Ministry of Health of India and the Public Health Foundation of India, so that we collectively can make smokeless tobacco history in the world. Thank you very much.